Today we'll be hearing from Associate Professor Clare Scott, one of Australia's experts on the rarest types of cancer. Clare will present an exciting new project that's offering hope to cancer patients suffering from rare cancers by providing a unique opportunity to become involved in medical research. Clare is a medical oncologist at Royal Melbourne Hospital and Royal Women's Hospital and laboratory head at the Walter and Eliza Hall Institute of Medical Research, studying drug resistance in ovarian cancer. She's a principal investigator of Cartwheel, the Centre for Analysis of Rare Tumours based at the Royal Melbourne Hospital and supported by BioGrid Australia. After graduating in medicine from the University of Melbourne in 1989, Associate Professor Scott trained at the Royal Melbourne Hospital and the Peter MacCallum Cancer Clinic as a medical oncologist. She performed her PhD studies at the Walter and Eliza Hall Institute of Medical Research, studying the interactions of blood hormones, and then worked extensively with mouse models of lymphomas, studying different aspects of drug resistance related to control of cell death. She furthered this work as a special fellow of the Leukemia and Lymphoma Society at the Cold Spring Harbor Laboratory on Long Island, New York. Associate Professor Scott has 15 years' experience in clinical cancer genetics and in treating breast and ovarian cancer, in particular those that occur in clusters in families. She's been awarded the Arnott Fellowship in Cancer Research by the Australian College of Physicians, the Seligson Cancer Fellowship at Cold Spring Harbor Laboratory, the Burnett Prize from the Walter and Eliza Hall Institute of Medical Research, the inaugural Corey Leadership Fellowship for Women in Science, and a clinical fellowship from the Victorian Cancer Agency. She's also recently been awarded the Sir Edward Dunlop Cancer Research Fellow from the Cancer Council Victoria and is laboratory head in the Stem Cells of Cancer Division at WEHI. We're absolutely delighted to have Associate Professor Clare Scott with us today. You can see she's a very obviously has an enormous amount of experience and has been awarded a large number of different awards, and we're very grateful for her coming to speak to us today. So please join me in welcoming Associate Professor Clare Scott.
Well, thank you. It's an absolute delight to be here today, and thank you very much for asking me to make the trip across. I am really delighted to be able to talk to you about a passion of mine, which is trying to target treatments to people's cancers rather than just treating cancer, which is often what we've had to do in the past. But targeting requires knowing a lot about each person's cancer, and there's a current term of personalised medicine, or personalised cancer therapy, which is coming into vogue. But there's a whole lot of research and work that needs to go on to make that possible. And in fact, rare cancers form a really important basis for some of that work. And that's the main message I'd like to give to you today. So the word rare conjures up a number of different things. Perhaps to the health system, it might sound like it's not too much of a problem because rare can't be common, can it? To a patient, of course, I'm sure it must be very frightening to be told not only that you have cancer, but that your cancer is rare. And perhaps that might mean that you worry that there won't be anyone with sufficient knowledge to actually tell you what sort of treatment you should have. And sadly, that's often the case. The confounding thing about this, though, is that although each particular type of cancer that is called rare is rare by definition, the rare cancers together make up a quarter of all cancers. So having a rare cancer is not actually rare. You're in good company. There are a lot of people who are diagnosed with a rare cancer, and that's actually a huge burden for our medical health system, and one that we're not yet adequately addressing. Research into rare cancers is not as widespread as it needs to be. So of all research dollars, less than 5% is spent on researching truly rare cancers. Yet, as I've said, 20 to 25% of cancers are actually rare, and up to a third of cancer deaths are due to rare cancers. So what are the strategies that we need to look into to really build research for rare cancers? Firstly, I'd just like to dwell on some of the absolutely pivotal reasons why this needs to be undertaken. But I don't want to spend too much time on these negative features other than to use them as a real reason for why we're all here today. So patients with rare cancers have less support of every sort. They have fewer treatment options, and they have a poorer outcome, especially if they're over the age of 60. And that's relatively new data for an important new study that I'm going to talk about in some detail. So we know quite a lot about the cancer incidence worldwide, and this is a slide or a picture that I pinched off the internet from the Cancer Research UK, and it's colourful and it tells you all sorts of things if you look at it closely enough. But you only need to look at this one ever so briefly to realise that there's nothing on it. It's not entirely true, of course. It's a little bit of a literary, an artistic game. But the bottom line is that any one type of rare cancer occurs at such a low rate that these patients really don't make it onto the map. Usually, cancer patients with rare types of cancer are not managed by a multidisciplinary team, which is really our aim in certainly the Australian healthcare system. That's due in part to a lack of funding, but also a lack of cohesion and infrastructure to build the right multidisciplinary team for that patient. And what it effectively means is that then there's a lack of access to a variety of skills for clinicians and researchers. So unfortunately for many patients and their families, there's no research available to guide management, no evidence-based treatment options, which is a real problem for the health system, let alone for patients, no clinical trials or research programs, and little support or information. So the barriers to effective research for rare cancers really lie around the fact that the patient numbers are so small, that patients of the right sort are hard to locate, and that they're geographically disparate. But what are the silver linings? Because for a lot of this talk, we're going to be able to talk about what has been done and what is possible and what we can do in the future. So one good place to start is with children. Now, children with cancer have been much better served internationally and nationally than adults, and that's for a number of reasons. Most children with cancer, by definition, have a rare cancer, and yet they do well. And in fact, the success of treatment for children has really skyrocketed over the last 30 to 40 years, and the 5-year survival is in the order of 80%, and many of those children are cured. And in fact, that means a lot of our health dollar is spent on trying to minimise the side effects of their treatment so that they can go on and live a full and normal life. Now, for a couple of reasons, many of those childhood cancers are actually more sensitive to a range of treatments that we have at our disposal today. But it's widely accepted that the real impact and success from management of childhood cancers came from the fact that some 20 to 30 years ago, it was recognised that because these cancers were so rare, their care and management had to be centralised, and many, many children were enrolled onto clinical trials. So even though they had rare diseases, those diseases would be aggregated into groups of cancer patients on a cancer clinical trial. Now, even if that wasn't necessarily looking at some new wonderful targeted therapy, it allowed data collection, it allowed us to see the real holes in what was known and what was not known, and it did allow us particularly to notice if certain treatments didn't work at all. So that really did allow spectacular improvements for children. And in fact, up to the age of 39, nearly 40, young adults with rare cancers also have as good an outcome as do patients with common cancers of the same age. So far up to the age of 40, say, having a rare cancer is not necessarily a bad thing, and indeed for a child, it fits into a paradigm of treatment care that has actually been successful. Now, another silver lining, and this also is relevant for adults, is that there are a range of certain types of rare cancers where, for a variety of reasons, your cancer may well fall into a tumour stream that really has quite good management. So here there is a multidisciplinary team who are used to dealing with something that's rare. And blood-borne cancers or haematology, run by haematologists is the best example of this. Because if you're a haematologist and you go to work every day, 70% of the patients that you see will actually have a diagnosis that's classified as rare. So guess what? Haematologists can't sit back and sit on their laurels and treat everything that walks in the door the same way. They are actually used to going back to the data, back to the literature, and really making sure they're on top of it for nearly all of their patients. And also the haematology clinical trials groups and researchers have been very well coordinated for many years now, internationally as well. So again, there is a lot of success within the haematology field. And in fact, for gynecological cancers, which is my area, gynecologic oncologists are also used to dealing with a large proportion of rare diagnoses. And I think that does make a difference because it means they're used to having to go and search out and find the best available information for a patient who's just walked through their door. But for most other types of cancer, the definition of a rare cancer, which I'm going to come to in a moment, really only accounts for less than 10% of what they do. So for a large proportion of their patients, they're staying at the cutting edge of this versus that versus something else, for whether bowel cancer or breast cancer or lung cancer, for example. But when it comes to a truly rare cancer in their domain, they're not actually as used to having to go and search out what would be required for that patient. Another silver lining, before we get on to the precise definition, is really to highlight the role that support groups have played for patients with rare cancers. So patients, their friends, their families, patient support groups, consumer groups, there are a whole range of terms used for this type of person. But these people have been the major forces for change in rare cancer management. And this goes back 20 to 30 years. In fact, in 1983, the Orphan Drug Act was passed in the United States, and this meant that for the first time in legislation, there were advantages for companies who were prepared to develop a drug targeting only a small number of patients. Now, most of the success stories there for those drugs came not for cancer, but for other sort of metabolic diseases. There is an example of one that I'll come to in a moment. But still, that underpinned the fact that governments needed to legislate to actually stand up for and do something about patients who had rare diseases. And that really only occurred because of the consumer groups that were lobbying for it. So patient support groups have been instrumental in shaping policy and in identifying and addressing unmet needs for rare cancer patients. And the NHMRC and a variety of Australian cancer-related groups have issued statements on the benefits of involving consumers in research, so that this is not just an idea on the side. It is a firmly held philosophy, and there really is quite a lot of academic literature to support the fact that consumer involvement is likely to be helpful. It's actually very hard to run a clinical trial to prove that, but often strong examples come through. So it's a feeling that the community itself is more likely to be better informed and to recognise the value of research and have a greater understanding about research strategies if consumers have been involved in designing it. If consumers can gain influence over research questions and priorities, research is more likely to be more relevant to the community needs, and therefore may contribute in a more meaningful way to health outcomes. So these sorts of statements are extremely important and have happened at the national and international level. An example of this is NORD, which has been around for some 30 years or so, and this is the US Association of Rare Diseases, and so they've been at the basis of a lot of these legislative changes. So that really brings me to what is a rare cancer, and the introduction from NORD comes from the fact that I want to make the point that an oft-accepted definition of 5 cases per 10,000 people is what is given for a rare disease rather than a rare cancer. And that's a figure of prevalence, which indicates if at one point in time you canvass an entire population and say, of this population of 10,000 people, how many have this type of disease, then less than 5 would have that. But that indicates that the people have to actually be alive long enough to stand up and be counted. And unfortunately in cancer that's not always the case. And so a new study called Rare Care from Europe, which has taken the last 10 to 15 years to actually report, and I'll describe it in detail because I think it's very important, they have made a cogent argument for the fact that incidence should be used when defining a rare cancer. So that means if you take 1 year, how many patients are diagnosed with each different type of cancer? And so the incidence that they now promulgate is less than 6 per 100,000 population. And so that's the figure that I'm going to take for my talk today, and I think going forward that is a helpful figure. But one should also tack on to the end of that the other requirement for a disease to be considered rare, for example by a lot of government, legislative and perhaps pharma groups, is that there has to be a real unmet need and something that can be achieved. So those are actually soft indications. And the bottom line for Cartwheel, which I'm going to get onto in a while, is that we are inclusionary, not exclusionary. So I think there are many cases where a particular type of cancer that's not been studied adequately should belong in the rare cancer basket. So Rare Care is this project which is surveillance of rare cancers in Europe. And this was established to estimate the burden of rare cancers in Europe. Its aim was to provide an operational definition of rare cancer because of the recognition that actually even the definition was difficult to get right, and to come up with a list of cancers meeting that definition. And a paper covering this was published just late last year and really, for the first time, forms a benchmark for this. So Rare Care was going to provide cancer burden indicators, which are incidence, survival, prevalence, and mortality, based on population-based cancer registries throughout Europe. And last year, in their publication, they really covered a 14-year period in this publication, which covered 162 million population, which constitutes about a third of Europe's population. And of those, the prevalence, so the number of people alive at that point in time with a rare cancer, was in the order of 4.3 million patients. Not sounding so rare, is it? And in fact, the incidence was 500,000 new cases diagnosed each year. So these figures came out with the same figures that I gave you at the beginning of the talk, which were from our Australian Institute of Health Welfare. And again, this magical figure of about 22%, so between a fifth and a quarter of all new cancer diagnoses were classified as rare, according to their definition of an incidence of less than 6 cases per 100,000 population. A really important point was that most rare cancer types were in fact exceedingly rare, less than 0.5 per 100,000. And the lists, the tables in this paper, really show very accurately how incredibly rare a lot of these subtypes are. So they gave another couple of pieces of information. This shows the age of patients with rare cancers shown in red. And as I said earlier, most children with cancers by definition have a rare cancer because they would fit into whichever of these definitions you're going to take based on the sorts of numbers I've been talking about. And here this is done based on the incidence of less than 6 per 100,000. And you can see that common cancers are very rare in this patient group. So going up to about the age of 40, you can see that there's a bit of a meeting of the curves. And then going forward, the rare cancer ages are slightly younger. So really, overall, the median age is slightly less for patients with rare cancers, but we do need to think about whether patients are less than 40 or over 60. And the reason for that is on this slide. So this is the data I've already talked to you about. So up to the age of 40, the 5-year survival for patients is equivalent whether or not they have a rare cancer or a common cancer. And for patients who are diagnosed with common cancers in blue, all the way out to 99 or overall, survival is up over 60%. But with increasing age, if you have a rare cancer, your survival is markedly reduced, and it's almost half that in this age group here, from 75 to 99. It's really important to recognise that because we need to ask why. And there are a number of reasons that might account for this, but this sort of data can't be put to one side. It means that we have to get on with solving this disparity. So I want to give some examples of rare cancers now that I have defined it. And this first example you might think doesn't sound so rare, but I want to explain why it's relevant. So squamous cell cancer, or SCC, you might be most aware of as affecting the skin, for example. So SCCs of the skin are very common and they're commonly well dealt with and removed and are not usually a problem. But if you get a squamous cell carcinoma somewhere else, for example, like in the lining of the mouth, oral cavity, larynx, and so on, then this can be a very dangerous cancer. Now, they're grouped together as SCCs of the head and neck, just reduced to SCC H+N. That's how we deal with them clinically, and there's actually a benefit to that. Let me explain it. If you actually look at each individual type of these cancers, then they are subdivided into these rare subgroups and are rare by definition. But they probably do somewhat better than many rare cancers because of the fact that they're grouped together for treatment. So the treatment, for good reasons, is designed for the group as a whole, and this provides, in fact, a great deal of expertise and advantage for these patients who have otherwise a rare cancer. So this is an example of a rare cancer which is better managed. But I just want to make the point that we still need to do further research to understand how to target treatment to these patients. So I'm certainly not saying that I think we've done all the work that needs to be done, but these patients fit into a group that is a bit better managed. Now, another example, that was one of subdividing based on anatomy. This is an example of subdividing a cancer based on what we call the cell type when we look down the microscope. So two of the major differences are adenocancer versus squamous. So adenocancers are gland-like in some way. They may not actually have glands, but they have some features of being like glands. Squamous cell cancers, on the other hand, like involving the skin or the lining of the mouth, involve a lining, an epidermis-like structure. Now, they spread somewhere else, but they still retain some characteristics. So usually it's pretty easy to determine which of these is the case for a particular patient. The point I want to make is that, for example, adenocarcinoma of the bowel, pancreas, stomach, and breast are the most common subtypes of those cancers, and they are common cancers. They have fairly well-defined treatment paradigms, even though we need to be a lot better, particularly at treating pancreatic and stomach cancer. But the point is that other cell types, so for example, if you had a squamous cell cancer or a whole host of other descriptions of cells when you look at them down the microscope, is that those other types of pancreatic, stomach, breast or bowel cancer are in fact rare. So you can have a bowel cancer and have a rare sort. So that's an example that relies on the histopathologist looking down the microscope. And does it matter? Well, it does, because other cancer cell types of common organs may not actually respond as well as does the common cell type of that organ. And that's because all of the information and the response for designing treatments for that type of cancer has been driven by the bulk of the patients, and those patients had the common cell type. So knowing that you have a breast cancer doesn't necessarily mean you know how you're going to go if you have a rare type of breast cancer, for example. So just a few of perhaps the better known examples of rare cancers. Mesothelioma, of great relevance here, and when you compare the European numbers for mesothelioma with Western Australians, I'm sure that it is rare in Europe, and it probably isn't here, but still. So here there's a great drive for research and better treatments for mesothelioma, and it is an example of where consumers were required to try to prevent this occurring by improving legislation and trying to gain some type of recompense for the great wrongs that were wrought for people who developed mesothelioma from asbestos exposure. The story about GIST that I'm going to tell you has a much more positive lining, and I'm going to then talk about hemangioendothelioma, which is a subset of sarcoma. And this is an example of the fact that sarcoma is almost an umbrella group, and it's full up of a whole lot of different subspecialty diagnoses, and hemangioendothelioma is one of those. So I just want to briefly mention this story about GIST. So GIST is gastrointestinal stromal tumour, and it didn't really get much above fine print till about 15 years ago. So I'm not sure how many of you recognise the drug imatinib, but it has been one of the most famous drugs in the development of cancer or blood cancer treatment. And that's because it was discovered that it worked for a particular type of leukemia called chronic myeloid leukemia. And because it worked exceptionally well, because it was targeted to the gene abnormality, the results were so good and so fast that this was the drug that had the fastest approval by the FDA. And a wealthy Scandinavian whose wife was diagnosed with GIST and found there was pretty much no knowledge, no treatments, and nothing in the offing for his wife, started reading the fine print. And he discovered that GIST was known to express or to have a particular mutation called c-KIT. And in the fine print, he realised that imatinib was known to hit this c-KIT receptor. So a cancer cell has all sorts of things on the outside, and in this case, c-KIT was one of those things, and he practically wrote the ethics application himself because he wasn't a medico, so the story goes. I hope I've got it all right. But the bottom line is that because of his absolute insistence on going ahead with what must have seemed like a crazy idea at the time, not only did his wife receive treatment, but the treatment of GIST was transformed. And this no longer has really just a rare cancer future with no chance of treatment, but instead a chance of long-term survival and a huge industry of pharma working on the second, third and fourth line drugs. So that's an example of what one consumer can do. And this is an example of what another consumer can do. So Cynthia Pollack helped us design Cartwheel, and I'll speak more about that in a moment, but I just want to describe to you her role. So her son Danny, on the right there, was diagnosed with a rare hemangioendothelioma cancer. And I still remember her saying to me that she had yet to meet a doctor until she'd generated a whole lot of interest and information who had ever treated a patient with HERD. And in fact, when he was diagnosed with this mysterious disease, there were only 6 patients in Australia with that diagnosis. But Cynthia being Cynthia, that just made her even more determined to come up with something better than there's no funding available to research such a rare disease. So with the use of a pretty simple home computer and a really only burgeoning internet, because we're talking at least 6 to 7 years ago now, Cynthia set about collecting 300 patients internationally. She did this by email largely. She collected their data. She was a one-off person doing this, so she had no ethics or consent, but these patients freely gave her their information. She not only tracked their information, but she provided online support such as she could for these patients. So although we wouldn't normally recommend a person who has no medical knowledge giving advice, when there's no one else available, she did an exceptional job of trying to simply pass on what information she had. And during the course of this, Danny's illness went on for some 10 years. He graduated in law, got married, had a baby, and then unfortunately passed away just at the time that the Cartwheel site was launched. But true to Cynthia and her approach, she and her entire family still came to the Cartwheel launch. And I just really give that as yet another example of someone who's made a difference. She now has a HERD support group website, which is going to amalgamate with a Cartwheel type website based with a research group in the US. And every so often she'll send me updates of the latest research that this group have now been able to generate, pretty much based on the patients that she put together. And they're now finding some genetic molecular abnormalities that will help them come up with possible avenues for treatment. This is another example. So Debbie Alablas, who is the mother of Eliza, is another outstanding expert patient or expert consumer. Her daughter was diagnosed with GIST, and I've just told you that that should be quite a good thing, really. But unfortunately in her case, not only was her daughter young, and paediatric GIST was even rarer than regular GIST, but Debbie realised that she had c-KIT negative GIST. So I've just told you that the advance consisted in the fact that the other guy noticed that imatinib could be used because of c-KIT mutations, but Eliza, her GIST, didn't have the right mutation. So when treatment with imatinib was recommended, it was actually Debbie who thought that might be a waste of time. So she went about searching and asking questions until she found the right doctor in Melbourne who was prepared to go to the right group in the US who had the most expertise and actually get a management plan for her daughter based on international consultation. And Debbie and Eliza are other members of our Cartwheel support group. And just this final example, this is small cell cancer of the ovary. Now, you may have heard of small cell cancer of the lung. Small cell cancer of the ovary is exceptionally rare. So again, a consumer, a rather wealthy family in the US whose daughter had had small cell cancer of the ovary, found a researcher and donated enough money to start this website, which is designed to collect, the aim is to collect 20 to 40 cases where there is sufficient data and also access to tissue for gene tests to be run on these types of cancers. So you need quite good tissue to be able to do whole genomics profiling, and that's what they're hoping to get. Now, the point about this last slide is that not everyone can actually generate a website for their cancer type, and not everyone has the ability to go out and recreate the world. And I'm not suggesting for a moment that that's what everyone in this room needs to do, but I will give a few hints at the end about how we can make a difference. But there is a very firmly defined concept which I hope I've illustrated to you with those 4 examples that will mean that you won't be able to forget the concept. The concept is that of the expert patient, making active decisions, not just being reactionary to whatever their doctor recommends. Now, I'm a doctor and I'm a medical oncologist, and I think normally you should think long and hard about what your doctor recommends, but I certainly think you should ask good questions. And if the answers that you get back are not based on evidence-based medicine, because there is no evidence, then you should keep asking questions. And if that means you have to go outside Perth or outside Australia or from one international group to another international group, that may be what's required. But certainly the expert patient these days is supported by the rapid emergence of web-based health information. And so the concept now is that you can join with other patients transgeographically. That's a rather horrible term, isn't it? It is hard for every rare cancer patient to have this approach or to have their own website, but together this will make an inroad into what is otherwise often a void of information. So let's just look for a moment at the internet in the medical landscape. So there are a range of healthcare providers that provide online resources, and some of these are easily recognisable as being likely to be of high quality. So those are websites associated with cancer councils or major comprehensive cancer centres, either within Australia or overseas. And in the UK, Canada, the US, other European sites, there are really major cancer centres that have fabulous websites. So I would always suggest starting there. And links from those websites for rare cancers are still probably the best way to begin your search. But it's really quite remarkable that although for any one person in this audience they might feel that they're not that computer literate, they probably are surrounded by family and friends who would be only too willing to help. And in fact, some figures show that up to 75% who want health information will search for it online. And in fact, the most prolific internet users are people with rare diseases and those caring for someone with a rare disease. And that's because they don't have enough options. Just a comment about social networking. It's probably doubled since I made this slide, but in this current climate, we need to use everything available to us to plan for the future, to harvest novel utility. And this will occur. There will be sites out there trying to provide things for patients. So the academic sphere needs to do that as well, to provide good options for patients. Why do we need to do things differently? Because what we're doing at the moment doesn't work. It doesn't work for a quarter of all cancer patients. So we don't want to just shift deck chairs on the Titanic. I just want to mention a concept that aligns to the current thoughts about treating cancer. So as you'd probably know, this idea of personalised medicine means we want to treat a person's cancer based on the gene drivers that are involved in that cancer. So certain genes are very important. They really allow a cancer cell to escape all sorts of regulation and also to escape drug treatments. And if we could identify those particular gene drivers and switch them off, the cancer should be dependent on them and that cancer cells should die. So that's, broadly speaking, the idea of personalised medicine. And it will become the way of the future, which actually means those common cancers that I referred to before are actually not going to remain common because they're going to be subdivided further again based on these gene signatures. So even the common cancers will end up having rare subtypes. And then, of course, we can go further down that and say when we do give a targeted treatment to a cancer, if it fails, it's actually probably because we didn't get the targeting right and we need to actually subdivide yet again. But when you get it right, there are spectacular successes with accurate targeting. And I think Professor Olver referred to some of those at his recent talk here. So I've got a couple of images to try to get this idea across. So one is that, we see what we see. And up here, we know if a cancer has occurred in a breast or a bowel or a kidney. But there are a whole lot of subsets underneath. And in fact, those subsets based on genes might be relevant for more than one type of cancer up here. And I'm going to show you another analogy for this in a moment. But for example, there might be some similarities, for example, between breast and ovarian cancer that track to one of these roots. And if we can identify it by this route, we can actually treat both the ovarian and the breast cancer types. But at the moment, a lot of this is hidden to us, which is why it's a subterranean root system. Now, genomics has great hope for helping us discover this, but we are right in the middle or even just on the precipice of entering into that. So there's quite a lot of work to be done. So another way of describing this is to think of breast cancer, for example, a common cancer type. Many of you may know that, depending which article you read in The Age, breast cancer is subdivided into 6 or 12 groups. My husband keeps telling me the number seems to be getting bigger. I actually work on it, but that's okay. Now, of these subtypes, which we do understand a lot about, in fact, they're similar to subtypes in a number of other cancer types. And as I mentioned before, there are some types of ovarian cancer that are similar to some types of breast cancer. And we're working very hard on new drugs called a PARP inhibitor, which might be suitable for both of these cancer types. That's just one example. So then there's another example which relies on something you might have read about in the press recently, this expression of a BRAF mutation. So it's most famous for accounting for 80% of melanoma, but it also accounts for around about 10% of colorectal cancer, and the figure's a bit more rubbery for ovarian cancer, but there are certainly going to be some ovarian cancers that would be BRAF mutant. Now, you need to understand the pathways, because the drug, the BRAF inhibitor, works better in melanoma than it does in colorectal cancer, but some of our scientists in the US have actually just discovered why. So we can actually get around that problem. We have to add in another targeted inhibitor, and that starts to make people a bit anxious. Not the patients, actually the researchers and the clinicians, because the clinical trials become more complex. But it doesn't mean we don't know the answer. We just have to work out how to get there. And there are a couple more examples of this. So this type of thinking is the way of the future. So breast cancer and HER2 targeting with Herceptin is the poster child of targeted therapy. Women who have this rarer type of cancer, it occurs for 15% of breast cancers, now receive HER2 targeted therapies from shortly after their diagnosis, and that has halved the mortality of this very lethal type of breast cancer. Now, we know that there are other cancers like stomach cancer that also have a HER2 positive component, but they're rare, and we actually are not doing a good job yet of looking carefully enough at these. So when you just throw the drug at patients where HER2 seems to be up a bit, it actually doesn't seem to work that well. But we need to understand more so that we can actually leverage off this sort of information. And then just a final example is that of ovarian cancer and renal cancer. So renal cancer is a type of cancer where, again, there has been a targeted inhibitor, it's available, and it works really very well. And this renal cell cancer subtype is described as clear cell. And it's been known for many years that there's a subset of ovarian cancer that's also clear cell in type. But this has always been treated with ovarian cancer type treatment until recently. And now there are trials, and we're pretty certain that we need to be treating this not with ovarian type chemotherapy, but with this clear cell targeted therapy. Just one word of caution, we need those histopathologists for a long time to come, or at least until we can get a better handle on the gene signatures, because there are clear cells that are actually like serous cancers, and they need the chemo. So we still don't have this quite right, but the philosophies here of trying to understand these things better are what will bring better results. So we need to identify driver genes, we need to exploit designed targeted therapy, and most of all, we need to match the right treatment to the right patient. So what we really need is a matching service, because that should produce better outcomes for patients and families. So when Cynthia Pollock came to BioGrid and said, "You're on about data integration, I've got all this data, what do I do with it?" Because it was a huge job for Cynthia to handle. Now, the problem was that because she wasn't an academic and hadn't been constrained by academic requirements, she didn't have ethics approval for those data. So we actually could not take those data from her. With the best will in the world, there was actually no way we could hold those data. But what we did do with her help was set about 5 years ago building Cartwheel. And the whole aim of Cartwheel is to be able to allow patients to input their own data in an ethically secure way. So the website has been dedicated to Danny, as you will see if you go onto the website, and this is Danny at his graduation. So this is the Centre for Analysis of Rare Tumours, and the idea of the wheel is that this needs to go round and round, and we'd like you to help us keep Cartwheel turning. The thing that makes it distinct internationally is that it's been ethically approved and that it's web-based. Now, to get this through ethics, we had to have really quite a forward-minded ethics committee, which luckily we have at Melbourne Health, and headed by Angela Watt, who was really prepared to listen to what we were saying about the needs. And in 2007, this was still actually pretty wild, the fact that you could consent a person from Peru to an ethically approved study in Australia. So the idea about Cartwheel is that we provide a whole lot of services and target them as is needed. So one person might be looking for research, another person might be looking for consumer support, it might be a person from a registry or a researcher looking for patients, but it is a matching service which should be able to link these people together. So the website design started in 2008, but now you can go to the website and register and enter your data into a streamlined questionnaire. So because we had a lot of consumers helping us design this, it's really very easy to use. For starters, you can't lose anything you put into it. So the way we did this with the ethics committee was to say there is nothing more heartbreaking than entering anything in online and then losing it, and it must be even worse if you're unwell and also putting in information that might be really difficult for you to deal with. So we elected that anything put into a page can't be lost, it's saved automatically, but we can't access it until we receive that person's consent form. So we hold data that a patient might end up deciding they actually wish they hadn't put in, but we can't look at it. So you should rest assured that unless we get that piece of paper in hard copy with your signature, naught will come to your data. So I'll talk a bit more about the questionnaire in a moment, but really this is the basis of Cartwheel, that you can learn about human research ethics committees online. You can download the consent form, which, as all consent forms, is fairly long. You can read it, print it, sign it, and then post it to BioGrid. So BioGrid Australia is the umbrella company that have allowed this to happen. They're a not-for-profit organisation, a secure research platform and infrastructure that provides access to real-time data across multiple jurisdictions, institutions and diseases. So this platform provides ethical access and protects both privacy and then intellectual property. So it's very important. This is a group with a great deal of expertise, and in my experience in Australia and internationally, there's nothing like it actually for being able to coordinate all of this. And so Cartwheel is just one of their many projects. I'd also like to point out that we've received great help and advice and wisdom along the way from John Stubbs at Cancer Voices Australia, and so this really has been a consumer-driven project. So the data that we collect focuses on trying to make sure that we can prove the diagnosis. So for any patient who has data in there who's ticked all the boxes on the consent form that I'll show you in a moment, we can actually write to that pathologist and obtain their pathology report to ensure that the diagnosis is as accurate as possible. And of course, for rare cancers, many times the block and slides need to be reviewed by an expert pathologist, and so clearly further down the track we know where the block is, so this can be done as well. So the location of the report and the tumour block are really underpinning what could be ongoing research. So we collect a range of data involving treatment, toxicity, follow-up data. There's a questionnaire about general health, which has been validated in other settings, and that's important because how a patient might respond in cancer generally is well known to be impacted on by their general health. We also collect family history data, and then gene testing of any sort that's been performed on either the person's tumour or on them or their family. And I'll explain those in a moment. So this is what the website looks like, although it's going to have a new look in about 3 months' time. And all the way through, we provide these hyperlinks. So if you hover over common tumour type, it will actually describe how a common tumour type might actually fit into Cartwheel. So all the way through, there should be easy learning with language designed by consumers. So when you start typing in what type of cancer you have, if you know you've got a rare breast cancer but you can only remember breast cancer, then you can put breast cancer in, and then there'll be a little sign that says next time you go to your doctor, ask for your pathology report and come back and update it. But the bottom line is you just start typing, and the whole of the DaVita textbook practically is in there, every which way round. So you can have English spelling, American spelling. You just look down and the list will be very long, but it will shorten with the more that you put in, and then you can pick the thing that's most relevant. And if you're not sure, you pick the thing that you think is correct, and you can always go back and fix it later. So we trialled a whole lot of calendars on home computers, and this was the one that seemed to work the best. This is an example of the family history information. So again, we describe how we divide up the various relatives, and this allows us to reconstruct from the back end whether patients are related by blood or not, on different sides of the family, and which types of cancers are in the family, and most importantly, the youngest age of any family member with that diagnosis, because we know that age matters. And this is about testing, so has anyone in your family been tested for an inherited cancer? And you can write either the doctor's name or the familial cancer clinic. You can even say, I don't know, if you're not sure. And then when you get into that, you can actually see choices, so either gene tests that are named or cancer syndromes that are named, because sometimes you know what syndrome you've got but you've never been tested, and sometimes you know what the gene test was but you don't know what syndrome is associated with it. And then also the tumour itself may have been tested for a particular gene or protein, and these might be things that are quite common, like the estrogen receptor, the HER2 receptor, and then they might also be a little less common. But if you've had that test, you may well know, or you can ask your doctor. So basically the consent forms are built for either a patient or a proxy. So we have 4 consent forms because ethically we have to have one for a guardian of a young child, a next of kin for someone who is deceased or unwell, and momentarily I've forgotten the 4th. So this is what the consent form looks like. And again, the ethics committee made us divide up all of these options so that it's absolutely clear. But really, we haven't ever had anyone who hasn't filled in yes for all of them, because the way Cartwheel is designed, that is usually the wish of the patient. But all of this is really designed so that even though you're not being consented by a doctor, this should be very clear. So just a little tiny bit of data about the first 100 patients that have consented. The types of patients that are in there are things that actually reflect some of our interests. So we are interested in sarcomas, in hemangioendotheliomas, as I've said, in GISTs, and in various subsets of breast cancers. This is a really important piece of information. I told you before that as people get older, they do less well with cancer, rare cancers. And if you look here, only 14% of patients who had entered their data in the first 100 had received 2 or more chemotherapy regimens. Now you think of the common cancers, and how most people would do if they had received no treatment or one chemotherapy regimen. In fact, common cancers would start to look like rare cancers probably, but the point is that doctors don't know what to give. The first one's probably a guess, and after the first one they're worried about doing harm and giving toxic therapy. So patients with rare cancers just simply don't even start to receive treatment, let alone the right treatment. And I'm certainly not advocating the wrong treatment, but this means we need more research, and it certainly could underlie the fact that a lot of patients with rare cancers don't do well. This is looking at the accuracy of data. So down here we have the diagnosis as typed in by the patient into the Cartwheel website. And for those patients, we had accurate data for them from a sarcoma database. And the similarities were very great. Not only that, but we knew that there were some patients in here where they were more accurate than the database, because not all databases can be updated all the time. And for something like sarcoma, the final diagnosis might actually be given a month or so later. So we know for some of these that this was the correct diagnosis. So my point here is that patients with a rare cancer, when knowing that they are really having to look at their treatment and what's going on, are highly capable of finding the correct diagnosis and being aware of it and keeping track of it. So patients who enter their data into Cartwheel get something back immediately. They get a PDF summary of all the information that they've spent time putting in. And this document is a living document. It can be updated and changed whenever you like. You just log back on and put in new data. So it might be 4 or 5 pages long if you have entered a lot of treatment data, for example. But it's designed to achieve 2 aims. One is so that you've actually got a good record of everything that you have spent all that time, checking up on and maybe writing out in hand. Well, here you have a nice document that's really easy to read. And it's also easy for any other doctor to read. So basically you could hand this document to the next doctor that you're referred to, and it might just make it somewhat easier to get information across. It's also useful for the family. So the advantages for consumers for Cartwheel are to learn about research, contribute data for research, signal their wish to be involved, to tick the box to be contacted for a clinical study, trial or a research study, and to print off this PDF summary. Basically, you can help drive the direction of research into areas which are currently considered too hard for the general research community, but in which you have a particular interest. So we have research projects online that you can look at if you just follow the research tab, and this is one of them in high-grade mucinous ovarian cancer. We're on Facebook, we're on Twitter. But what we have not had yet is a good consumer support forum. And remember that I explained that Cynthia Pollack was doing a huge amount of that for the families that she collected information from, and it is a really hard task. And it's not something that we could ever get into as doctors and scientists, but we really were very interested in finding a group that would provide that for Cartwheel. So Rare Cancers Australia is a new group run by Kate and Richard Vines. It's going to be launched in October. This is their fabulous art logo. And they have a number of aims: to provide support, education and government advocacy for patients and their carers with rare cancers, to provide improved patient and carer support, the type of support that Cynthia was providing, to improve education for health professionals about early diagnosis, and also to help link patients to doctors with an interest in their type of rare cancer. Also to lobby for funding for research and to lobby for advocacy to the federal government in encouraging improved access to treatments for rare patients. So they and we, Cartwheel, are hoping to link our sites so that on our Cartwheel site you do all of the hard yard of the academic information, data type end of it, and then you follow a link to their site for the consumer support. And equally for them, they will be focusing on consumer aspects, and then they will have a link to Cartwheel so that their patients are able to go to an academic, ethically approved, privacy-protected website and contribute their data and become involved in research. So why should we do things differently? Why am I spending all of this time talking about this? I mean, we know that we've already had a lot of groups involved in delivering healthcare and in trying to address the different aspects of cancer care delivery and cancer research, but we still haven't done well enough. And we know that there are many different groups who are coming together, but there's much need for improvement. So what we do know is that we have this hyper-connected society now, where sometimes Twitter backfires, but if used appropriately, social media and the internet can be used to great advantage. And I think it's really a question of us working out together how to do this safely. So the Forgotten Cancers project is a project run out of the Cancer Council Victoria. This is a little bit different to Cartwheel. They're looking at the less common cancers listed here, and it's a one-off. You fill out an epidemiological questionnaire and provide a saliva DNA sample and possibly a blood sample, and we're linking with them, so then if you want ongoing involvement in rare tumour research, you would be directed to Cartwheel. The Rare Care Group that I described have now published this year, just in the last few months, April to July, 10 publications, each geared towards a different rare area of the cancer research covered in their big paper last year. These types of data have never been available, so they will underpin where researchers and indeed consumers should be looking to try to improve outcomes. So what can you do? So even just being here today and listening means that you will be able to go back out into the community, and if you come across people with rare cancers or questions about cancer, you will be educated in this field and be able to respond. And even if you can just pass on the message to Google Cartwheel Rare Cancers or like us on Facebook or tweet on Twitter about us, these things can be really important in drumming up support and providing patients with options. On the Cancer Council WA website, there's a great explanation about consumer involvement. So to find that, just put Cancer WA and consumer into Google and it will take you straight to that page. So really just make sure that people know that they can make a difference. And it is good, I think, to use academic bodies to help you to do that. But never feel that one voice isn't enough, because look at what Cynthia achieved. So I'd really thank you for listening today. Just show you some, you can always test out Cartwheel if you like, just ask me for the login and password. There's plenty of contact points on the website if you'd like to ask questions. And this is the team, because this took 5 to 6 years to produce, and there are a whole host of people with expertise there, ably headed by Maureen Turner, the CEO of BioGrid. And they're the BioGrid contributors. Thank you.
Just have time for a couple of questions, if there are any questions in the audience. Covered it so well, Claire, that no one needs to ask you any questions. Oh, there's one just there. There we go.
Thanks. With tumours, G'day. With tumours, I'm a farmer. First thing we start off when we look after our soils is pH. Do you guys look at pH with tumours? And
so broadly speaking, in the lab, where if we get the pH wrong, everything goes haywire, yes, we do have to pay particular attention to pH in our culture medium, for example. I guess in cancers, pH is affected by things like lack of oxygen. So we know that in solid tumours where you have a lump of cancer and not very good blood supply to the middle, that the centre of that cancer can become oxygen deprived and quite acidic. So that could potentially be an advantage, because maybe the centre of that piece of cancer might then break down. But cancer cells do devise ways of getting around things like that. They tolerate environments that shouldn't be tolerated. Yeah, well, or acidic environments, but that's right. And so the metabolism of cancer cells is very good at getting around things that would normally cause a healthy cell to die. So I think the alkaline and acidic nature of the body is fairly well controlled by all sorts of body systems that normally remain pretty much intact till someone's very unwell. But I think your question does relate to, these sort of unusual environments that develop within the centre of some tumours.
Any other questions? Okay. Well, would you please join me in thanking Associate Professor Clare Scott for her very fascinating talk. Thank you very much.